So I'll be speaking about surface ablations with mitomycin C, its complications and management. Uh, so surface ablation basically means altering the radius of curvature of the anterior corneal surface using a laser technique, which is the excimer laser. The word excimer basically comes from a combination of two words, excited dimer. The gas most commonly used these days in the excimer laser is argon fluoride gas. And the interesting part in the history of this is that the engineering behind it was given by an Indian scientist named R. Srinivasan. So what happens is basically initially the two molecules are in low energy state and they are activated by a laser beam, and once they come back from a high energy state to a low energy state, they emit a photon which is has a wavelength of 193 nanometers, and this has the ability to break down all the carbon-carbon, carbon-nitrogen bonds. This is how your excimer laser works, ablates the cornea. The first PRK was performed in 1980s in Germany, but FDA took its own sweet time to give approval based on the results in 1995. So there have been successive generations of excimer laser starting from the first. Now we are into the sixth generation. Initially, we started with broad beam laser with fixed optic zones, which actually had a very led to very high incidence of complications with surface ablations like haze and all. But now that we are into faster ablation rates with good tracking systems, most of the refractive surgery has become very predictable and the complications have minimized. So as I said, older systems had broad beams, and there was variation in the amount of energy delivered with every ray of laser delivered, which led to more complications like under or over correction or inaccuracy in the correction of the refraction. The newer laser systems are high-speed lasers. They have fast trackers, so the less incidence of decentrations. Pupil monitoring systems again help us with reducing the incidence of decentrations, and they give us better customization profiles. Now, the types of surface ablation procedures available are PRK, LASIK, epi-LASIK, or transepithelial PRK. Basically, in these, as I already described, we remove the outermost layer, that's the epithelium, with the help of multiple ways. Either it can be with the help of alcohol or manual removal, or with the help of a blade as in epi-LASIK, and then subsequently a excimer laser is fired to alter the shape of the cornea. And so basically they are all different names, but actually have similar outcomes. They work the same. They have similar outcomes in terms of pain perception, speed of epithelial healing, visual recovery, and final outcome. We at Center for Sight prefer doing a PRK over and above other procedures. So coming to the complications which have been described, I'll be dividing the complications into short term, which are pain, delayed visual recovery, subepithelial haze, keratitis, and other epithelial healing issues, and steroid-induced glaucoma, because we have to use steroids for longer duration and higher frequency as compared to other refractive surgeries. So the incidence of glaucoma is slightly higher. Coming to the long-term complications, they can be under and overcorrection, regression, decentration, haze, corneal ectasia, dry eye, and visual phenomena like glare, halos, etc. We need to really counsel our patients well for all these complications, because the delayed visual recovery and haze are the most common things that happen with most of the refractive surface ablations. And the pain post-op also needs sometimes oral anti-inflammatory. So coming to post-inflammatory pain, post-operative pain, post-PRK, it stays there for 3 to 5 days, and most patients will need oral anti-inflammatory agents. There have been 3 different mechanisms described for this pain. One is an inflammatory pain. The other is a nociceptive pain that happens because of the bare nerve endings which are left after the ablation, and neuropathic pain. So for the treatment of these, first the bandage, contact lens, the tight bandage help with the nociceptive pain because it reduces the movement, rubbing of the eyelids with every blink onto the exposed nerve endings. And for the inflammatory pain, we use topical and systemic anti-inflammatory agents as per the need. There have been studies and reports of gabapentin being used for the neuropathic component of the pain, but it is highly controversial. Coming to another short-term complication, keratitis, that can be further divided as non-infectious and infectious. It is very important to differentiate between the two types of keratitis. Coming to non-infectious keratitis, it's usually a staphylococcal marginal hypersensitivity reaction. It's a type 3 hypersensitivity reaction, and the infiltrates are usually marginal, and there is history of rosacea or blepharitis present. And there is no important sign is that there is no anterior chamber reaction noted in non-infectious keratitis versus an infectious keratitis, which will usually have an anterior chamber inflammation. And in this, what happens is basically the bacterial antigens from the lid trigger an immune response with deposition of complement complexes in the peripheral cornea, activating the complementary pathway. So coming to management of non-infectious keratitis, it's usually a self-limiting condition, usually resolves in 2 to 3 weeks with topical corticosteroids only. And the signs of healing are just like any other infiltrate. The resolution of epithelial defect will be seen, the cellularity of the surrounding cornea will decrease, and the infiltrate margins will start to show rounding as the infiltrate starts responding. It is important to emphasize in such patients about lid hygiene and antibiotic ointments for the lids. And it has been shown that systemic doxycycline also helps in such cases because of its anti-inflammatory and anti-collagenollytic effect. Coming to infectious keratitis, now infectious keratitis in refractive surgery can be of two types. It can be either early onset or late onset. Early onset is when it presents within the first week and accounts for majority of the cases, 50 to 60% of the cases, and it's most commonly because of a bacterial infection, which can be either staphylococcal or streptococcal. The late onset after 1 week is a slow growing, or usually because of a slow growing organism like non-tubercular mycobacteria, NTM or nocardia or fungi, etc. So this is one of the largest series about infective keratitis post vision correction. They studied over 7 years retrospectively the refractive procedures, which were about 6,45,920 procedures, and of those only 101 eyes had some form of keratitis. And as you can see in the table, the culture proven microbial keratitis was much lower in PRK as compared to LASIK in this study, and even the probable microbial keratitis was much lower, and the LASIK had more incidence of marginal keratitis. So the similar management of infective keratitis is usually similar to management of a corneal ulcer. We should scrape the infiltrate, identify the organism, and do a targeted antibiotic therapy. This is a flowchart given by Das Shilpa et al. In their recent paper in IJO, where they have described for the first 1 week after the scraping, they prefer starting fortified vancomycin, moxifloxacin to cover for the most common organism, and in more than 1 week old infiltrates, they prefer starting amikacin and moxifloxacin to cover for the non-tubercle mycobacteria and other slow-growing organisms. And they wait for the microbiological workup and then start basically based on that. Now, coming to long-term complications, the most common complication is haze, which occurs actually in less than 2% of patients in low myopia group and occurs in about 8.6% in the high myopia group. It can lead to refractive regression and glare and reduction in best corrected visual acuity. There are two types of haze basically described. Type 1 tends to appear 1 to 3 months after surgery and tends to disappear within few months after surgery. Type 2 is a late onset corneal haze, which appears after 3 months of surgery and persists for more than 3 years and sometimes permanently as well. The ablation, so factors which are responsible or are involved in haze formation are ablation depth, the amount of ablation we are doing. Because we do more ablation for the higher grades of myopia, the incidence of haze is higher in higher myopias. The integrity of the basement membrane, if it is not intact, it can lead to haze. The deposition of abnormal extracellular matrix as a part of wound healing process is another factor responsible for haze formation. Moving further, as I already described, if you're correcting higher myopia, higher astigmatism, you have a patient with autoimmune condition, and these are the conditions where the chances of haze formation are more. Interesting study by Stovanovic and Nitter has shown that the higher exposure to ultraviolet radiation can lead to a late onset haze. So areas where the UV exposure is more, those patients can be probably asked to wear UV protective glasses for about 1 year post surgery. That's what they have recommended. There's a grading system described by Hitzman, which is used for management of corneal haze in the first 0 to 2 grades. Topical steroids or topical non-steroidal anti-inflammatory drugs are sufficient for the treatment. Grades 2 to 4 usually need mechanical epithelial debridement with adjuvant like MMC or a laser scrape with a PTK or excimer laser treatment. Grade 5 is basically a corneal opacity which eventually needs a corneal transplant for visual rehabilitation. So this was a female patient who had developed haze towards...
Sorry to interrupt, sir, but the time is up. You need to conclude. I'm really sorry for this.
Yeah, I'm just concluding. So for prevention of haze, as I described, topical steroids and use of MMC is important. MMC is basically alkylating agents used in 0.02% concentration for 15 to 120 seconds. And the rule is basically 10 seconds for every diopter corrected. And this should always be necessarily followed by a thorough saline wash. This is the chart we follow for our patients usually. And the complications related to MMC described are either vascular endothelial injury, which is rare after refractive surgeries because the MMC in these cases are in contact with the avascular tissue that is cornea. And epithelialization is slightly delayed in cases where you will use your mitomycin C. There is a controversy about whether the keratocyte density increases or decreases after mitomycin C use, and there is a definite decrease in the endothelial cells post use of MMC, and this is directly related to the time of contact, and the higher the thickness, higher the ablation. So other adjuvants which can be used to reduce haze are oral vitamin C, systemic steroids, cold BSS lavage after surgery, and there are trials going about plasma rich in growth factors to reduce the haze. Dry eye, Raghav has extensively covered, so I'll be skipping. Under and overcorrection was more common in the previous days, but these days it's very rare. Refractive regression basically is gradual, partial or complete loss of refractive error which has been corrected, and usually because of epithelial hyperplasia and stromal remodeling. Ectasia is very rare again after PRK. It's reported only in about 4% of the cases. Decentration is also uncommon these days because we have better tracking system. Abrasions again are less as compared to LASIK, but are more in patients with higher pupillary diameters. So management, the over and under correction can usually be corrected with the second procedure if there is adequate thickness left. And we have to wait for 3 to 6 months before stability of refraction before proceeding with the retreatment. So I prefer doing PRK in patients with thin corneas or patients with recurrent corneal erosion or corneal dystrophy, patients who have...
Requesting you, sir, please to conclude the presentation as we have to...
Last slide. So there are certain intraoperative considerations to prevent complication. Incomplete epithelial removal could be cause of irregular refractive result, and plain removal of epithelium can lead to hydration changes. We recommend performing excimer laser within 1 minute after the epithelium. If patient loses fixation briefly and refixes immediately, the ablation can continue. But if there is a rapid loss of fixation without an immediate refixation, laser should be stopped immediately. Thank you.